Well, good afternoon and welcome to our weekly Gecko sessions. It's a great pleasure this week and indeed an honor to welcome you all to this special Gecko session. It's the launch of GI Gecko Pathology, which we've had in mind for many months, but we didn't really know how to kind of launch this subspecialty. I'm very grateful to Professor Martin Hale, our pathologist this afternoon, and to Bilal Bobat, a trustee of the foundation, who during the lockdown invited me to attend their Wednesday lunchtime weekly liver histopathology sessions. And it was during those sessions that I was once again reminded how perfectly poised hepatic histopathology and indeed clinico-pathological sessions which incorporate clinical hepatology and clinical and hepatic histopathology are so perfect in introducing pathology, and hence the launch of this new initiative. We obviously will spend many weeks and much time concentrating on hepatic histopathology, but the idea is to extend these sessions to other forms of pathology. And I'm very pleased that we have a number of general pathologists with us this afternoon that will perhaps benefit from these and other sessions. Immediately, the pathology of inflammatory bowel disease comes to mind. And in sub-Saharan Africa, the need, for example, to differentiate inflammatory bowel diseases from tuberculosis is an important entity. And we have planned many sessions in concentrating on that. The pathology sessions will alternate with the other Gecko sessions of endoscopy, inflammatory bowel disease, patient blood management, and viral hepatitis, which is so superbly run separately by Professor Wendy Spearman. And we also plan to incorporate or introduce a multidisciplinary approach to the screening and treatment of liver cancer in sub-Saharan Africa. So with that in mind, then, allow me to allow Masheko Shedi to chair the session. I hope you enjoy it. Feedback from you will be very important, and thank you for your attendance today.
Thank you, Chris. I think Chris has been talking about pathology for as long as I can remember, and he's quite passionate about it. So I am pleased for him that he's finally seeing this to fruition, thanks to the Project ECHO model. I have spoken previously about Project ECHO and what it does and its aims, and I would refer you to previous recordings on the Gastro Foundation website if the model is still unclear to you. And of course, you can look it up as well online. As Chris says, this is the first offering of the Gecko pathology meetings, and we are all hugely excited about the possibilities. And just as a sign of the demand for this, we've had 99 registrations. We have people from all over the continent. Thank you so much for joining. People from Madagascar. We have individuals from Australia, Japan, the United Kingdom. Welcome to all of you. I hope you find this session exciting, and I hope you will learn from it. And I think today we are quite fortunate to have Professor Hale, who's based at Johannesburg, as he says. He's a specialist anatomical pathologist who spent an entire career, which is quite a long career, working in the public sector, both in South Africa and in Zimbabwe. He has extensive experience in diseases that affect sub-Saharan Africans, infectious diseases, malignancy. He has recently been collaborating with Professor Mahdi in the investigation of the SARS-CoV pandemic. They've also previously collaborated on childhood mortality. So there's no question that he is a fitting individual to be the first speaker for this, our first Gecko pathology session. And I'm looking forward to his presentation. We thought it would be appropriate for him to talk us through the approach to the normal liver anatomy, histopathologically speaking, because of course, going forward, the cases that will be presented initially will involve liver anatomy and pathology. And as Chris says, we hope to morph into other disorders for which pathology is very, very sorely needed, particularly in the continent. So I welcome all of you, pathologists, non-pathologists, clinicians, to this platform. I think this promises to be a very exciting meeting. And after Prof has spoken, he's willing to take questions, so please do type them in the chat function. Then we will do the questions, and then we will have a case presentation that will be illustrative of what we're trying to demonstrate. So with that said, I'm going to hand over to Professor Hale, and we look forward to your talk. Thank you so much.
Can everybody hear me? It looks as though I've got a very unstable internet connection.
No, we can hear you perfectly.
I'm sorry about this, but Wits has had a problem starting yesterday. Stop me if you can't hear me. So first of all, I'd just like to say a great thank you, big thank you, to Professor Cassanides for asking us or asking me to talk.
Prof, I think we've lost you there a little bit. If I may ask all the participants to, if you haven't done so yet, to please switch off your videos and your microphones just to help with the technical issues. Thank you. Prof, if you can hear me, we'll give you a few moments to maybe reboot and try to reconnect with us. Thanks.
Again. Karen, do you think it's worth me connecting through my cell phone?
Prof, why don't you let me show your presentation and you can just tell me when to advance the slide. Let's see if we can make that work.
Link on my cell phone, that's the problem. Okay, let's start. So I go to share then my screen.
I've just done that for you, Prof.
Okay, right. I need to go full screen. What? Nothing seems to be happening.
No, I've got the control.
Okay.
I'll switch to slide mode.
Okay, right. All right, so can I now control it, Karen?
Cheryl, is there a way of handing over control to Prof Hale?
No, you've got the screen, Karen.
Okay.
So we can request remote. Let him see.
There you go. I've moved to the next slide. You can just tell me when to advance.
Yeah. Okay, so well, welcome everybody, and as I've expressed my thanks to everybody. So I thought I'd just start off with the also primarily the basic microanatomy of the liver, because everybody shies away from liver pathology because it's found to be pretty difficult. But in fact, in reality, it's actually very easy. And it's like everything, if you understand the basics, then in fact, it's pretty easy to work things out. So first of all, everybody knows where the liver is situated in the right hypochondrium of the liver. And here you can see that we've got a large right lobe and a smaller left lobe, separated by the but I've also really directed the talk at many of the trainees and registrars in anatomical pathology who are present in other countries to the north of us. So if I could have the next slide, please, Karen. So there's the surface markings then of the liver. We've just seen a photograph of that, the undersurface of the liver, and to recognize that one of the most important anatomical square centimeters of the liver. Remember that the inferior vena cava also comes up through the groove in the liver, and another vascular structure. So next slide, please.
Prof, I'm sorry to butt in there. We lose chunks of what you're saying. Is it possible to maybe reposition yourself in the office, or?
No, I think Mash, it's the WITS internet.
The internet. Okay.
Has been misbehaving late yesterday afternoon and today, and it looks as though it's got worse now.
Okay, well, we'll keep going and see how we do, because at some point it is clear, but sometimes it just disappears. Okay.
Late, if I should just use my cell phone, put some data onto my cell phone, but that'll take a while to do so. Could I have the next slide? No, this is not working.
Are you not seeing the slide that says zones?
No, I've still got the surfaces, the surface anatomy.
Mashika, what can you see?
I see the slide with the zones. So the slide that we are supposed to be on.
Okay.
Yeah.
I'm just wondering, Prof, maybe it might not be a bad idea to have Bilal present his case first. And then what you can do is see if you can get onto, your machine where you'll be showing us the slides of the case.
You see the is that I'm going to need fairly fast internet to show you the histology, because that's live video.
Yeah. What do you prefer? What do you think would work? It might give you time to reboot.
I'm going to have to change the network.
You're going to have to?
Change the network. I'm going to have to use my cell phone as a hotspot, I think.
Would you be able to do that then to show the case?
Yeah, so Karen, could you send me the link to my WhatsApp? I don't know if one can connect via WhatsApp.
So I think let's try that, Prof. I think while you try to connect for the case that Bilal is going to present, then we can have Bilal do the case, and then hopefully we'll be able to get onto the slides of the case. Is that fine?
Masheka, another option is maybe to just get some chat going on our audience and see what people feel about these sessions and any ideas? I mean, you know, from Gecko as a whole, maybe we can just start a chat session while they get the act together.
I mean, that is an option. I'm just mindful of the time that it's already 4:20. So maybe
But I
it
think
would be
even if we,
possible to get the case.
yeah, even if we, okay.
I mean,
Okay, and then if we got to pause afterwards, maybe we can do it
yes,
that way.
yeah.
Perhaps, you know, put, okay.
So Bilal,
Okay.
are you happy? Are you happy to share, and you can start discussing the case?
So,
yeah, we can see it. Thanks, Bilal.
okay. So I've actually got Dr. Ostrovsky here with me, and we actually, he was my fellow at the time of seeing the case. So it's convenient that he's popped in to join us here. Mr. BM was still is a 34-year-old gentleman, presented chronically ill with clinical AIDS. His presenting symptoms were severe loss of weight with constitutional symptoms and notably diarrhea. Dysphagia was noted in the course of his management. Drug history, he was on ARVs, regimen 1, the fixed dose combination since January of 2020. He had no additional herbs, supplements, or traditional medication, and stopped consuming alcohol on the diagnosis of his retroviral disease in January. Clinical exam revealed a wasted individual, marked temporal wasting. There was pallor with no stigmata of chronic liver disease. He did have a hepatomegaly with a liver span of 18 centimeters. There was no ascites and no splenomegaly was noted. His laboratory investigation showed a hemoglobin of 9 with an MCV of 76, a white cell count of 1.7, and platelets of 290. His liver enzymes were notable for a mildly elevated bilirubin, specifically when compared to the elevations in alkaline phosphatase of 3,131 and gamma-glutamyl transferase of 2,742. The transaminases were mildly elevated, as you can see here, and an albumin of only 24. His hepatitis markers were negative. He was hepatitis B immune. EBV PCR was negative, and of note was a CMV viral load of over 1 million international units. His autoimmune markers, ANF, was negative. His angiotensin converting enzyme was elevated at 110, with a normal at our lab being anything from 20 to 70 international units per liter. A TB gold interferon was performed, which was indeterminate, and a cryptococcal latex antigen test was negative. His CD4 was noted to be less than 100, sitting at 72. And at the time, his HIV viral load wasn't too bad, sitting at 73. Radiologically, an ultrasound of his liver was performed and showed mild to moderate hepatomegaly with coarse echotexture. There was no evidence of biliary obstruction, no mass lesions noted, so an MRCP was performed considering the significant cholestatic picture. The major ducts did appear smooth with no evidence of stricturing. There were small foci of altered signal within the spleen representing either possible microabscesses or granulomata. They did note on the MRCP that there was a very small amount of ascites. So this left us thinking, considering the very low CD4 count and a CD4 count of less than 100, normal bilirubin with such markedly elevated cholestatic enzymes would suggest possible HIV cholangiopathy. That was one of our differentials. the history of constitutional symptoms, and his marked wasting suggested possible mycobacterial infection, and that was something else that we started looking for. And we therefore requested a liver biopsy in view of this normal MRCP to try and answer both of these questions. I'm not sure if Prof Hale is ready. Is he back online yet?
There we go.
Prof Hale?
So maybe we could, Mash, maybe we could open it up to the floor, just in terms of what everyone else's thoughts are.
Yeah. Okay. Why don't you unshare? Was that your last slide, Bilal?
That's my last slide, just in terms of presenting the case.
Okay. To the participants, are there any questions that you'd like to pose to Bilal regarding the case? Anything that was unclear? Any other investigations that may or may not have been done? Any explanation for the biochemistry or any of the blood results? Please feel free to share. Also, if you do see patients who present like this, and what the diagnoses are, or what your considerations would be for this patient. So please feel free to unmute, put on your camera, and just let's have a discussion.
Prof. Christian Tsitsun, I see you joined us, I think, from Rwanda.
No, Cameroon.
Cameroon, sorry. Any comments from you regarding the case? I just see one of the comments, regimen 1A is emtricitabine, tenofovir, and efavirenz is our South African regimen 1A.
Bilal, how long had he been on that regimen for?
Since January, and he presented to us in at the beginning of October,
Okay.
29th of September.
Wisdom is asking why the dysphagia.
We'll get to that, Wisdom.
And was the biopsy transcutaneous?
We did go for a transcutaneous biopsy, yes.
Okay.
So Bilal, when you've got a cholestatic picture biochemically, what makes you decide to sort of explore the biliary tract radiology, and when do you decide to do a liver biopsy, and in what order? Because this is often a dilemma. You know, liver biopsies are invasive, and if you can get away with something.
Yeah. So I think that as non-invasive as possible initially would be the way forward. And as you can see here, we did the MRCP prior to getting the liver biopsy on this patient. A liver biopsy does come with risk. It is not an entirely benign procedure, with complication rates of, I think it's 0.005%, which is significant if you're ordering a lot of biopsies, such as we do at high volume centers. You need to ensure that you've got your protocols in place for monitoring these patients once you've done a liver biopsy, because there is always the risk of bleeding in these patients. I'd go ultrasound. In the right context, you look at your autoimmune serology, consider primary biliary cholangitis. We've got HIV as existing condition, and that's an important consideration here. An adequate history, make sure that this patient hasn't, in terms of drugs, toxins, or prolonged ICU stay for any causes of a secondary sclerosing cholangitis, any operations, those sort of factors can impact. And then progress to, and if that doesn't give you an answer, then consider a liver biopsy. I see Wisdom has considered amyloid disease. I think that's a very very good suggestion, seeing as he's got advanced retroviral disease with a low CD4 count. But prior to January, he wasn't necessarily ill from his amyloid. His renal function was also noted to be normal. And although you can have normal kidney function in the early stages, I suppose you'd expect some proteinuria with those sort of patients.
Somebody said that CMV cholangitis as a differential. I think that's in the cards, and certainly not unreasonable.
Yeah.
Igembe Nkandala says conserving the diarrhea, or I guess they wanted to say considering the diarrhea and cholestasis. Did you consider Cryptosporidium, which is associated with diarrhea and cholangiopathy? Again, a very, very reasonable.
Absolutely.
Very reasonable.
Yeah. So, I mean, with cholangiopathy, they've picked up all sorts of potential causative mechanisms, including Cryptosporidium, CMV, I think even isospora. A lot of your infectious diarrheas they felt can result in cholangiopathy. Unfortunately, if you look at treatment for HIV cholangiopathy, it really only seems to be immune reconstitution. That really helps, and then possibly ursodeoxycholic acid, which has resulted in improvement of symptoms, and biochemistries.
So apparently, Prof is back. There is one more question I'd like you to answer, because I know we have histology on that, but somebody has asked, clinically, without giving it away, what were the endoscopic features at gastroscopy?
So at gastroscopy, we did note that there was some pharyngeal candidiasis. This was not extending into the esophagus. It was fairly limited to the back of the throat. Once at about 25 centimeters, there was what appeared to be a healing ulcer with a degree of nodularity around it, and I was uncertain as to what this lesion was due to, and we took biopsies from the ulcer bed and from the edge of that lesion. The gastroscopy, the rest of the gastroscopy was normal, possible mild gastritis, but no real ulceration or anything in the stomach or duodenum. We did take biopsies in the duodenum and in the esophagus.
Okay. Prof, I'm certainly dying to see the slides of the liver and the esophagus. Have you been able to reconnect so that you can show us the pathology, Prof?
Yep, I have. Can you all hear me?
Perfectly, yes.
Okay, so I don't quite know how to switch off my cell phone. I hope you haven't got an echo.
There's a little bit of an echo, but it doesn't seem to be interfering too much.
I don't know how you switch the sound off. I just put that over there.
You don't need to be connected to the cell phone, or you could just switch it off now that you've established connection on your computer.
Yeah, so maybe I've got two things going.
No, there is a bit of an echo, Prof.
I think I've got 2 meetings going. I think that's the problem.
And we're not seeing your slides yet.
No. How do I switch this off?
And Masheko, no one's dropping off. We still got 77 participants. So thank you to the audience for their patience.
I mean, I think everybody's dying to see this case.
Okay, right. How's that? Can you hear me still now?
Perfectly, Prof. Yes.
Okay, great. I'm a little bit of a technophobe, so I'm sorry about that. Okay, right. So I'm sorry about the presentation. We can still do that. Shall we quickly do the presentation or not?
No, I think given the time, Prof, maybe we can just get to the case.
Okay, all right. Now
We could probably do this, the presentation at the next PAT session, Prof.
Okay, right. So I got to share my screen and no. Let's have a look here.
We do see some H&E beautiful slides.
Yeah, great. Okay. So, but is that large enough?
Yes,
Full
I think it's high power. It looks like high power.
Yeah, but you've just got a little.
We're getting it on a nice full screen, Prof.
Are you getting it on a full screen?
Yeah.
Yes.
So how do I go back out of this? Oh, this is frustrating. So all I've got now is, so have you got a full screen?
No. We've got the histology on the slide that would normally show your face. And then on the larger screen, we've got you're on the long meeting page.
Let me stop the share. Can I stop the share?
Now we can see the full page slides, Prof. So this is perfect.
You see the full thing. Okay. Yeah. So unfortunately, all I've got is a thumbnail. But anyway, it'll be fine as long as you can see the full.
We can see a beautiful slide. Thank you.
That's great. Okay, so I must apologize profusely. Unfortunately, the university network has really let me down. So now the Galaxy A5 has come to the rescue. So I hope I've got enough data. I should have. So what we've got then in this liver biopsy is a really lovely cores which have been taken from this particular patient. And what is striking is in fact that there is a multifocal granulomatous inflammatory process, as you can see in this area here. Can you see the pointer?
But we can see the granuloma, Prof.
You can't see the pointer?
No, we can't see the pointer. But I think the pathology is glaring.
Okay, so we've got these multiple granulomata. They are non-caseating for the most part, but in some areas there is a suggestion of early necrobiotic change. But you can see these numerous epithelioid histiocytes, as you see there, and a couple of giant cells. You can see a multinuclear giant cell just in the center of the screen. There's a little bit of steatosis, both large and small droplet steatosis. And I was going to tell you all about the pathology of steatosis as well in the liver, but that's for next time. And then there's a small little granuloma as well. When I saw this for the first time, I thought to myself, okay, this looks pretty much like a granulomatous hepatitis. And living in this part of the world, I think one has to think of tuberculosis first, second, and third.
Mm.
But he was also HIV positive, or he is HIV positive. And I think if we look at this particular portal tract, which you can see there, you can see that we've got a hepatic arteriole, right in the center of the screen. We've got the portal vein there. And I'm not sure just above the hepatic arteriole whether or not that's a bile duct or not. You can see that there's lots of hemosiderin as well in the portal-based macrophages. Here, we've got another portal tract, and one can see the hepatic arteriole. You can see the, to the left of it, you can see the bile duct. And if we look there, we can see that that bile duct in that particular location is starting to show some abnormal changes. We can see that we're losing the biliary epithelial cells, and there's dropout. There's a bit of irregularity as well. In fact, I think what I'm going to do, you should be able to see that.
Okay.
Great. Okay, so that's perfect. So you can see that there's irregularity to the biliary epithelial cells, and you can see that the biliary epithelial cells have been lost in that area there. The other thing that we also have is irregularity of that bile duct. And we need to compare that, for example, with this bile duct, and the morphology of that bile duct is relatively okay. Then moving down to this area here, we have another portal tract. A portal, at least the portal vein, the hepatic arteriole. What's important about this is that there's a complete absence of bile ducts in that portal tract. When one goes through the liver biopsies, and there's several cores, you can see, in fact, that there are several portal tracts where the bile duct has either disappeared or it is fading. And here we can see a portal tract again. We can see the hepatic arteriole, portal vein, a bit of hemosiderin as well. And then in this area here, a bile duct that is certainly looking very sad. You can see that the biliary epithelial cells have been lost. So, and then another portal tract, once again showing you the same changes. And in this particular instance, in fact, I think the arteriole has also disappeared, but the portal vein, and there's no bile duct there either. So this is very suspicious, and this is also a very good area, portal tract. You can see the arteriole, you can see another arteriole there, but a complete absence of any bile duct. So what we're going to do now is look at the ZN. And in fact, before I show you the ZN, I want to show you the PAS stain, because I was quite taken aback when I saw the PAS stain. So you all know that we do the PAS stain as a matter of routine on the liver biopsies. And there you can see in sort of negative technicolor, if you like, you can see that these are the portal tracts. Some of them have got this granulomatous inflammation. And then we're going to have a look at this one here, and you can see under higher power magnification, this is the ×40 lens. And here you can see bacillary structures. And I thought, gee, this shouldn't be the case if this was TB. And interestingly enough, that is the only granuloma where that is the situation. You can see that these granulomata, for example, are completely devoid of any bacillary structures. There could be one there just at the tip of the arrow. So moving to the ZN, the Ziehl-Neelsen stain. This is the same granuloma, and they are strongly positive with the ZN. But what is interesting about this is the acid-fast bacilli are lined up in sort of parallel rows next to each other. And for those of you who are used to seeing acid-fast bacilli, these are a little bit larger and may be a little bit more angulated. difficult point really to demonstrate, but certainly you've got these almost sort of sheaves of wheat type of appearance with these acid-fast bacilli. So we've got acid-fast bacilli that are Zn positive and also PAS positive. So that means, or certainly indicates, this is an atypical mycobacterial infection. So this is not tuberculosis. This is something like MAC or one of the other atypical mycobacteria. So it's a fascinating case because we've got a couple of pathologies here. And then I want to move now to the Zeal-Nielsen, at least to the CK7 stain. And the CK7 stain stains up biliary epithelium. And what we've got here through the various biopsies, if we look, for example, at this stain here, you can see that there are numerous bile ducts there. You can see the bile ducts nicely demonstrated, and there as well. So those are original bile ducts. But if we look in other portal tracts, we can see that the bile duct is absent. So this is another portal tract here, and all we have is stem cell metaplasia, and it's fairly mild stem cell metaplasia in the zone 1 hepatocytes. There's no ductular proliferation which is taking place, whereas in that at least that portal tract, you can see the bile duct is there, but it's certainly looking rather atrophic. And that picture is replicated in several areas. Here's another portal tract. You can see a complete absence of any bile duct, and instead, all we have is stem cell metaplasia of the adjacent hepatocytes. Another one as well. So if we go through and count these bile ducts and in the portal tracts, about 50%, in fact, less than 50% of the portal tracts have an original bile duct. So this is HIV-related cholangiopathy occurring in this patient as well. A truly amazing case.
Indeed.
And then, Bilal, have you spoken about the esophagus?
Yes, Prof. I presented the gastroscopy findings.
Great, okay. So there is another portal tract, and once again, completely surrounded by stem cell metaplasia in the zone 1 hepatocytes. And notice the complete absence of a native bile duct. So now we're going to move to the esophagus. The pathology continues.
So, Prof, before you do that, was there no CMV hepatitis?
No, there was no CMV hepatitis.
Okay.
CMV immuno was negative, yeah.
Okay.
So this is the esophageal biopsy, and so just to orientate you, so you've got the superficial mucosa, which is situated there, benign, non-keratinizing squamous mucosa, and then in the underlying submucosa, absolutely crammed full of cytomegalovirus infection. And here you can see these numerous inclusion bodies, intranuclear inclusion bodies. And in fact, it's so stunning that I hope you can see it, but you can even see intracytoplasmic inclusions as well. So this is a typical example then of cytomegalovirus esophagitis. You can see the inclusion bodies here. This really is a textbook case. And the other thing as well is, in view of his HIV positivity, as we know, we've always got to think of unusual or usual conditions, if you like, in unusual locations. And I think you certainly would not be remiss if you interpreted this spindle cell proliferation to be possible Kaposi sarcoma.
Yeah.
And the HHVH is actually negative. So I think this is just spindle cell proliferation in response to the cytomegalovirus infection. So he hasn't got CMV, but he certainly has, he hasn't got Kaposi sarcoma, but he's got cytomegalovirus esophagitis. And this is the CMV immunohistochemistry. And there's that same biopsy fragment. And here, in the picture builds there, we can see the strong staining of cytomegalovirus inclusions. And you can see both cytoplasmic and nuclear staining. I'll just see if I can find a good example. A lot of the cytoplasm, in fact, is obscuring. But there's probably a fairly good example. You can see the positive nucleus and the cytoplasm also positive around that. So there we have a patient then, HIV positive, atypical mycobacterial infection causing granulomatous hepatitis, HIV-related cholangiopathy, and cytomegalovirus infection of the esophagus.
Thanks, Prof. I think that was a fascinating case. And I think just a typical example of the multiple comorbidities that patients with advanced retroviral disease or any immunosuppression, I suppose, can present with.
Yep.
Bilal, how was the patient managed? How is the patient doing?
So the patient was due for follow-up with one of my infectious disease colleagues yesterday. Unfortunately, although he did do his blood, so he is still around, he did not arrive for his appointment. So unfortunately, I can't tell you exactly how he's doing. Other than that, his bloods have shown some improvement. His CMV viral load has dropped from over 1 million to 683 international units per mil, or copies per mil. His LFT remains in a similar sort of range. It has improved slightly, but I wouldn't say significantly. His gamma and alk phos are still sitting in the mid 2000s. He was placed on MAC therapy, so rifampicin, ethambutol, and a macrolide. He was placed on ursodeoxycholic acid and then valganciclovir as treatment for the CMV. Considering the rifampicin use, we did switch his ARVs, seeing as his viral load was still somewhat positive.
Yeah.
The thought was I think with the addition of rifampicin to rather switch to another agent, and honestly I've forgotten which agent they went with, but yeah.
So based on the pathology, can you readily explain the micro and the macro steatosis? Is that drug induced? Is that due to any of the pathologies that were found on histopathology?
I think it's a combination of, I think it's multifactorial. I think it's the retroviral disease. I think possibly you can blame some of the ARVs that he was on, possibly efavirenz can do that. The wasting that he hadn't been eating well by his own admission, which would also result in a degree of steatosis. So I think the steatosis is multifactorial.
Yeah. Prof Hale, would you also say the steatosis is in keeping with all of his pathologies?
Yes, very much so. And in fact, actually, it was actually the steatosis was also one of the things that tripped me up from the point of view of TB, because we know that we get steatosis often with TB. And so the presence of the steatosis, because it's not a lot there, but it is there, you often get that with TB.
Yeah. Mark Sonnerup, he's my brother. He's a professor at Cryptosporidium Hospital. He's a hepatologist. So he published a paper on clinical pathological correlation in patients with advanced HIV. Mark, I wonder if you could comment on whether this is the type of pathology you would have expected even before the biopsy, and what other things do you see in patients who are presenting like this And also finally, if you're still seeing this sort of pathology now that, you know, a lot of South Africans are accessing ARVs compared to, I think, when you published the study.
Yeah, Sis Mashiko, thank you very much. Thank you for thanks, Martin. Thanks, Bilal, for a great case. Thank you.
Pleasure.
Yeah, you know, just kind of looking at it, I'm reminded that we wrote a small paper in 2008 on the value of liver biopsy in advanced HIV. And I'm pleased to say that being a person of consistency, I haven't changed my mind. Because in that particular case, we demonstrated and diagnosed cryptococcal neoformans and MAC, as well as HIV cholangiopathy in a patient very similar in nature. And the problem is in our practice setting, this is something that one comes across, and it's very problematic because you need to obviously treat the patient. They're ill, they've got advanced immune suppression, and all the therapies we're going to use have potential for hepatotoxicity. And so you kind of are caught in a rock and a hard place where you need to do something, but you need to have a handle on what you're doing. And I think this case demonstrates, you know, the need for biopsy and the need why pathology needs to be on the forefront of managing these patients. So, you know, the one interesting thing is that for our colleagues around the entire sub-Saharan Africa, the one really interesting thing in sub-Saharan Africa, and I think it's highlighted here again, is that despite the degree of immune suppression we see in patients with advanced HIV/AIDS, MAC still remains relatively uncommon in sub-Saharan Africa. You know, if you look at the initial series from the 90s and early noughties with respect to, you know, these kind of patients, you see MAC popping up in North America, European cohorts, for example, but it always remains genuinely uncommon. And I mean, in our case series of over 300 patients, we only saw it in about 3.5% of patients, in fact. TB by far and away remains the commonest. So when you find MAC, it's an uncommon finding, but you know, very important one. In terms of, excuse me,
lymphoma.
Yeah, I mean, obviously, high-grade B-cell lymphoma remains a big issue in patients with advanced HIV, or even as we're seeing patients get onto ART, it still remains in the background. And it, of course, liver biopsy remains an important potential diagnostic aspect of in fact, making that diagnosis, although lymph nodes and getting to the heart of the diagnosis and bone marrow remains the more important pathological specimen. But having said that, I mean, I think the interesting thing here is the, you know, so I think you know, summarizing what I'm saying is finding multiple pathologies in these patients is not unusual. In our case series, about 17% of people had multiple pathologies. So that's almost 1 in 5 people. And the interesting thing here is looking at everything is the you know, the actual bile duct situation. And the MRCP did not pick up and did not suggest that there was cholangiopathy. There probably is. And there clearly is a ductopenic process underway, although you can clearly see there's a superb attempt to try and maintain, actually maintain the bile ducts and to regrow some. Of course, cholangiopathy is important, but we mustn't forget, and I'm not sure, I just don't recall, Bilal. Obviously, we use things like, you know, like cotrimoxazole prophylaxis, which of course has the potential for bile duct targeting as well and producing ductopenia. So those are just additional things to think of. In terms of your last question, just to wrap up, I mean, I think there has been a transition over the last decade as ART has soared and become more available in sub-Saharan Africa. Certainly in our practice, we're seeing perhaps less of this and more of the drug-induced liver injuries consequent to therapies, lymphomas, etc., coming to the fore on pathology. Thanks very much for a really great case. Thank you.
I'm mindful of the time, but I must get a comment from Professor Olusegun Ojo, who's based in Nigeria. Prof, I wonder if you could just offer a brief comment. I mean, there'll be lots more sessions where we can engage more fully.
Oh, Sally, thank you for asking me to make a comment. Unfortunately, my connection has been very poor indeed. and I missed quite a lot of the material presented. I was excited at the histology of the liver and of the esophageal biopsy. And I think it was a great case that was presented today. I look forward to joining subsequent sessions on the pathology. Thank you very much.
Thank you so much. It's great to see you online.
Thank you.
So it is 5 o'clock, and despite the technical challenges, I feel like we haven't even begun. I mean, I think you'll all agree that the case presented was really illustrative of the type of complexities that we deal with. And I think if one doesn't have dedicated pathologists or access to any pathology, then you can imagine what degree of pathology is missed and how this impacts on the patients. So, you know, even despite the technical challenges, I just feel like we are onto something really good. I hope you thoroughly enjoyed the case that was presented. I thought the histology slides were superb. Thank you, Prof Hale. They were just beautiful. Thank you so much for that. I really appreciate it. And even though we couldn't get to the didactic talk, as Bilal said, we can do it next time. So, you know, we get to do it again. And so it really leaves for me to thank Prof Hale for, you know, a wonderful showcase of what is possible. Bilal for the wonderful case presentation. I have to thank the University of New Mexico, Albuquerque, for the platform and for allowing us to use it and to expand it as we have. I have to thank the Gastro Foundation, including Cheryl, Karen, and the ECHO India team that always supports our efforts. I think it's amazing that we've had so many participants from all over the place. I really thank you for attendance, and I hope you continue on this journey with us. And also, you know, log in with the other meetings. I hope you're finding them useful. We appreciate any input that you might have as to the format, the structure, anything you might want to hear. And as I constantly say, you know, feel free to put on your camera and your mic if you have anything to say. You know, comments are welcome. And really, we're just trying to get to know you, to get to know who's out there, so that we can share practices and experiences. Just to remind you that on the chat function, they have posted a survey or feedback. Please do fill it in. And I look forward to seeing you again the next time around. I think, as I said, we have a lot to offer. So I really look forward to seeing you next time. Take care and have a fantastic evening. Cheers.
Thanks very much, Mash. Thanks, Bilal. Thanks, Chris. Well done. Thank you.
Thanks, Prof.
Look after yourself. And hopefully next time we'll get the working, get the electricity working properly here at Wits.
It's still worked out. I mean, your slides more than made up for that.
It was great. Thank you. Thank you, Martin. Thank you.
Pleasure, pleasure. Look after yourselves, everyone.
Thanks, Prof.
Thanks, Chris.
Everybody north of our borders. Hi, everyone. Yeah, good to be in contact again.
Thank you very much. Yeah, we enjoyed that. Thank you, Martin.
Good.
Thank you.
Pleasure,
Thank you, everybody.
Very nice meeting. Thanks, Chris.
Okay.
Bye.
Bye. Bye.
Bye. Yes. Bye, Mashiko.
Bye, Prof. Good to see you.
Bye. Thank you. Nice seeing you.
Yeah,
Nice to see you.
Thank you. Bye. Bye.